In 1994, I began my career as an interventional cardiologist. I had just finished my cardiology training in New York City, and I was really excited to be moving to sunny San Diego. Why was I excited? Because I was going to Scripps Clinic, where they were doing cutting-edge work in the treatment of coronary artery disease. One of the procedures I was doing at Scripps was putting stents into blocked arteries. In fact, at the busiest part of my career, I was placing over 750 of these stents per year. Now, a stent is a metal sleeve, like the coil on a notebook. In fact, one of the first stents invented looked just like the coil on a notebook. Stents could be as small as a few millimeters. And putting a stent in an artery is a very precise technique, because usually we're not opening the whole artery, we're just opening a small section of the blood vessel. Stenting is one of the true miracles of modern medicine. It allows us to open a blockage in an artery and restore blood flow to the heart muscle in a matter of minutes. For many of my patients, that meant the difference between life and death. And for many others, it meant the difference between having chest discomfort with minimal activity and no chest discomfort at all. I was fixing only small sections of a single blood vessel. But the human body is filled with blood vessels, from the bottom of our feet to the top of our head. So was I really curing heart disease? Let me give you some staggering statistics. With all these miraculous tools in our toolbox, over 400,000 bypass surgeries a year, over 1 million stents a year, 2,200 Americans die each day of cardiovascular disease. Coronary heart disease claims 1 in every 6 deaths. Each year, we have approximately 795,000 people experiencing a new or recurrent stroke. And women are not spared. 42.7 million women are currently living with some form of cardiovascular disease. Now, another tool physicians have in their toolbox is statin therapy. Statins are cholesterol-lowering medicines that can reduce the risk of cardiovascular events. For many years, my colleagues and even myself thought that these drugs would be a cure for heart disease. But despite all the available statin therapies on the market, large studies with thousands and thousands of patients, even if people are on statin therapy, they can still go on to have a heart attack or a stroke. It's not that we're not spending the money. In the United States, $2.5 trillion was spent on health care last year. It is predicted that $4.3 trillion will be spent by 2023. If you think about that, that's 16% of our nation's gross domestic product. And it's double the amount of other developed nations. Yet, despite spending all this money, the United States ranked 37th in the world in health outcomes. A lot of our money is being spent on pharmaceutical therapy. When we look at all the pharmaceuticals made for the entire world, North America consumes 47.7%. In 2010, Americans spent $310 billion on pharmaceutical therapy. $13 billion was spent on statin therapy alone. Surgery and drugs are the hallmarks of Western medicine, and they definitely can be effective. I would be the last person to tell you that Western medicine, the kind of medicine I learned in medical school, has no value. Western medicine is great for acute care. For example, if you're having a heart attack or a stroke, or you've just had a car accident, that's when you want to get to the best state-of-the-art Western medical facility. This is what we're good at. However, conventional medicine falls really short in some very important areas, specifically illness prevention and chronic disease care. We are more trained to be reactive. If you have a heart attack, we mobilize and get you taken care of. We are disease-driven. I'm not even sure why we call it healthcare. Our focus is on disease. We treat parts of people. I'm a heart specialist, so I'm expected to just treat the heart. And I was trained to just treat symptoms, deal with problems when they come along, and then do a treatment. There's a reason for this kind of training, and the reason is this. As physicians, we are taught to ask our patients one question when we walk into the room. And this is a bizarre question, but it is, what is your chief complaint? What is your problem? Why are you coming here today? It already implies you have a problem. We then hear the chief complaint, maybe do a physical exam, run a few tests, and quickly we come at a diagnosis. Once we have the diagnosis, we then decide on a treatment. Well, this works great if your chief complaint is chest pain. You can bet you want to be in that Western medical facility if you are having a heart attack, because you're going to say chest pain and we're going to ask one or two other questions, quickly arrive at a diagnosis, and immediately initiate therapy, whether it's oxygen, medication, or even take you to the cath lab for a stent. It's that quick, it's that reactive, and it's life-saving. So our primary training in conventional Western medicine is to arrive quickly at the diagnosis. Rapid diagnosis leads to rapid treatment, and rapid treatment can save lives. It allows us to control the underlying problem, as we say, control the physiology. So we focus on the chief complaint, we make the diagnosis, and we quickly move on. Problems arise when we take that model of acute care medicine and we apply that to chronic long-term health issues. And that model certainly does nothing to prevent illness. The clinician is taught to proceed directly to the diagnosis, to name the disease, in order to identify as quick as possible a medication or a procedure. But when we apply that model to chronic disease, look at what we are missing. If someone comes to my office and they say, I have a headache, I make the diagnosis and I give a prescription, and I'm off to my next patient, I would be missing the essential aspects of that person's life. I'm missing who they are, who they live with, what they eat, what are their joys and their hopes. Do they exercise? What medications do they take? there are all sorts of questions that I would be losing out on. Socially, are they married? Are they isolated? Do they have community? Do they gain strength from their belief system? All of these pieces would be missing. The results of using the acute care model is little attention is paid to the patient's story. What we get is the chief complaint, maybe a little bit about the present symptoms of illness. The patient's whole story is not understood. Who is this individual in context to community? Each major issue becomes a discrete diagnosis dealt with in isolation from all the others. Remember, we were trained to look at the parts. So what do we end up with? We end up with what can best be called the ill to the pill. Every ill that we have, every diagnosis that's made, we reach into our toolbox and we take out a pill. So for example, if someone has arthritis, we say, let's give you this Motrin or Aleve. If someone has high blood pressure, we give a pill for that. If someone has diabetes, we give a pill for that. If someone has heartburn, you got it. We have a pill for that. So every label that we have, everything that we have a diagnosis for, we have a pill or a surgery because that's what's in our toolbox. The problem with the ill to the pill approach is you end up with a bag full of pills. I remember the day my patient Joe came to the office. Joe was just discharged from the hospital, and he had a bag full of pills. Joe had pills for heartburn, for depression, for high blood pressure, and for diabetes. And the first thing Joe said to me was, I don't like the way these medications make me feel. When can I get off them? Do I have any options? Now, if Joe had come to me in the 90s, when I was placing those 700 stents each year, I probably would have said, you know what, Joe? I'm afraid you really don't have options. You should be happy to be alive. You need to take your medications, period. But fortunately for Joe, by the time he came to me, I actually had something of a revelation. My practice had been radically changed by a simple insight. When it comes to the prevention and treatment of disease, nature provides the best solutions. So here's what I said to Joe. I said to Joe, I'm not against medication, Joe. There's a time and place for medication. And I do use plenty of medicines in my patients. But I let Joe know that medication, which is great for acute care, was not necessarily the best way for him to go forward in his life. Medication was not the best way to manage each and every one of his chronic health problems. And Joe seemed really surprised. Now I had his attention, and he said to me, you mean there really is another option? I said the answer is yes. And that option is the science of natural healing. Joe looked at me and said, what is the science of natural healing? So to explain this concept, I drew a tree. And I asked Joe, I said, if this was your tree and the leaves on this tree were sick, what would you do? And without hesitation, Joe answered. He said, I would water the tree. I would check the soil. I would make sure it was getting enough sunlight. And I even would add fertilizer. I want to strengthen the soil. I then explained to Joe that his tree was sick. And I drew a few leaves on the tree so that Joe would be able to understand. And I labeled those leaves: diabetes, heart disease, heartburn, high blood pressure. And I explained to Joe that Western medicine starts with the leaves. We go right up to the leaves, we name them, and we go for a medication or a surgery. The leaves are cut off, they're bypassed, or they're medicated. Joe seemed to understand, but I offered Joe a different solution. Think about this, Joe. Remember what you said about the sick tree. What if we look at your soil? We all have a soil in which we live. And if you take a minute, think of yourself as a tree. And you might even have a few health challenges. You might even be able to label some of the leaves of your tree. Maybe one is depression. Maybe one is diabetes. Maybe a leaf on your tree is high cholesterol. Maybe it's even heartburn. And some people have a lot of sick leaves. Now take your imagination a little bit further and think about the trunk of the tree. And I want you to imagine that the trunk of that tree, of your tree, is your genes, your genetic makeup, the book of life that you were given. And now I want you to go further. I want you to go into the soil, and I want us to look at what makes up the soil. Because at the end of the day, what determines whether we have healthy or sick fruit is a very special interaction between our genes and our environment. And the soil is the environment in which we live. So let's think about those important ingredients to the soil in which we live. They are things like macronutrition. What kind of protein do we eat? What kind of carbohydrates do we choose? Do we eat good fats or bad fats? What about our micronutrients? Things like vitamin D, zinc, selenium. These are all part of our soil. The human body also needs clean air and clean water. Our soil is also going to be affected by our physical activity. Do we walk every day? Do we have a formal exercise program? Do we do Tai Chi? This is a key component to our soil. But it doesn't stop there. Our soil is even affected by whether or not we have sound sleep at night. And our soil is affected by environmental toxins. All of these things interact with the trunk of our tree, with our genome, and determine if our leaves are sick or healthy. But it doesn't stop there. Those are just components of the physical body. Our soil has other equally important components. How we live our lives in community. Are we connected? Are we socially isolated? How are we doing emotionally, mentally, spiritually? Are we angry? Are we hostile? How do we see our glass? Do we see our glass as half empty or half full? Where is our resiliency? Do we believe in a higher power? Where do we gain our strength? So when I think about the soil, and when I think about my soil, I have to look at all of these areas. Because we know that the physical aspects of healing cannot be separated from the emotional, mental, and spiritual. And all of these, which make up our soil, ultimately determine whether we get sick or whether we stay well. I spent many years stenting the branches of my patients' trees. It would not be unusual for me to wait in the cardiac catheterization lab and call over to the emergency room and say, "Is anyone there having a heart attack?" And rush in, take them to the catheterization lab, and put in a stent. In fact, it did not even faze me in the 90s when my patients would go up to the ICU and they would be eating a roast beef and mayo sandwich on white bread. In the 90s, I had a total disconnect between intervention and prevention. I never thought about it. But I have spent years learning, and I now know that we have a better way. Whenever I talk about the ill to the pill, I think about a cartoon that I frequently use in the lectures for my patients. And the cartoon is two guys in lab jackets, like hospital lab coats, and they're both mopping up a mess of water that's on the floor. But there's a sink right in front of them, and the water is running from the faucet. So the water is just coming out, and they're mopping up the mess. I like this cartoon because it reminds me exactly of what I was doing. I was the one with the mop. I was mopping up the mess. I was the one that was waiting for someone to come with a heart attack, and then I would go in and put in a stent. It never occurred to me at the time that what I really needed to be doing was reaching up and turning off the faucet. I now know that the best way to heal the tree, to heal your tree, is by strengthening your soil. Not everyone needs the same thing. For some, it's nutrition. For others, it's exercise. And maybe for someone else, it's stress reduction. And some of us need a few. In this course, I will share with you all of the scientific evidence and practical techniques that you will need to strengthen your own soil.